Today we are going to talk about hyperkalemic periodic paralysis, or HYPP, in horses, including how an inherited sodium channel defect produces sudden attacks of muscle tremors, weakness, paralysis, and sometimes respiratory collapse. HYPP is caused by a mutation in the SCN4A gene, which encodes a voltage-gated sodium channel and skeletal muscle. The altered channel can become abnormally leaky and fail to regulate sodium movement normally. Muscle cells become excessively excitable, producing fasciculations and tremors, but sustained membrane depolarization eventually prevents normal contraction, leading to profound weakness or paralysis. Potassium shifts out of affected muscle cells and serum potassium may rise to approximately 6 to 9 milliequivalents per liter during an attack. HYPP is not contagious. It is transmitted genetically as an autosomal dominant trait, meaning one abnormal allele is enough to produce disease in either sex. An NH horse bred to an unaffected NN horse has approximately a 50% chance of producing an affected foal, while an HH horse passes the mutation to every offspring. Horses with two copies are generally affected earlier and more severely, although even horses with very mild signs can still transmit the mutation. During an episode, the horse may develop rippling muscle fasciculations over the neck, shoulders, and flanks, prolapse of the third eyelid, swaying, staggering, dog-sitting, or complete recumbency. Unlike a seizure, the horse usually remains conscious and aware, and unlike tying up, the muscles are generally not persistently painful, and the horse may appear completely normal once the episode ends. Paralysis of the upper airway or respiratory muscles can produce loud breathing, stridor, suffocation, or sudden death. Attacks may be triggered by fasting, stress, transportation, illness, anesthesia, sudden feed changes, or high-potassium feeds such as alfalfa, brome hay, molasses, kelp supplements, and some electrolyte products. Diagnosis is confirmed with a DNA test using mane or tail hairs with their roots attached. Blood collected during an attack may also demonstrate hyperkalemia. For a mild attack in which the horse remains standing, the veterinarian should be contacted immediately. Careful walking may help, but only when it is safe because the horse can suddenly collapse. Feeding grain or approximately 60 to 120 milliliters of light corn syrup orally provides glucose, stimulates insulin release, and helps move potassium from the bloodstream back into cells. A severe attack is an emergency. A veterinarian may slowly administer 23% calcium gluconate at 0.2 to 0.4 milliliters per kilogram, diluted in 1 liter of 5% dextrose. Calcium does not remove potassium, but it helps stabilize electrically unstable cardiac and muscle cell membranes. 5% dextrose may also be given at approximately 6 milliliters per kilogram to promote insulin-mediated potassium uptake, sometimes with sodium bicarbonate at 1 to 2 milliequivalents per kilogram to encourage potassium movement into cells. Severe upper airway obstruction may require an emergency tracheostomy. Long-term prevention begins with genetic testing and avoiding breeding affected horses. Affected horses should receive small, regularly spaced meals with a controlled potassium concentration, commonly around 0.6 to 1.1%, while avoiding prolonged fasting, abrupt feed changes, and large meals of potassium-rich forage. Later cut Timothy or Bermuda grass hay, appropriate grains, beet pulp, regular turnout, and consistent exercise are often better tolerated. When diet and management are not enough, a veterinarian may prescribe acetazolamide at 2 to 4 mg per kilogram orally every 8 to 12 hours. Acetazolamide is a carbonic anhydrase inhibitor that alters renal electrolyte handling and can help stabilize glucose and potassium concentrations. Another option is hydrochlorothiazide at 0.5 to 1 mg per kilogram orally every 12 hours. Hydrochlorothiazide is a thiazide diuretic that blocks sodium and chloride reabsorption in the distal renal tubule, increasing water and potassium excretion. Both medications require veterinary supervision, electrolyte monitoring, and attention to competition medication regulations. The big takeaway is that HYPP is a lifelong, dominantly inherited sodium channel disease, not a seizure or ordinary tying up episode. Genetic testing prevents transmission, while consistent low-potassium feeding, regular exercise, avoidance of fasting and stress, preventive medication when necessary, and rapid emergency treatment provide the best chance of preventing paralysis and death.